Spinal anesthesia, also known as subarachnoid block, is a type of regional anesthesia in which local anesthetics are injected in the CSF, which eventually bathes the nerve root and produce surgical anesthesia. So the indications of spinal anesthesia are lower extremity surgeries, perineal surgeries, lower umbilical surgeries, and even cesarean section can also be done under spinal anesthesia. But there are certain contraindications as well. Absolute being infection at the site of injection, lack of consent, severe valvular stenotic diseases, and relative contraindications such as hypovolemia or prior spine deformity. After proper patient counseling, proper patient positioning is a key for a successful subarachnoid block. We can give this block in a sitting or a lateral position. Anyway, we have to give our patient arched back position. So giving this position opens the intervertebral spaces and increases the target area as well. We have to palpate the highest point of the iliac crest, which corresponds to the L3-L4 intervertebral space. To perform a subarachnoid block, there are basic requirements such as a sterile spinal tray. We require 2 syringes, one for local infiltration and one for performing the spinal anesthesia. Here we are using 0.5% bupivacaine heavy for the subarachnoid block, and we require a spinal needle as well. So as we introduce our spinal needle, the layers pierced from outside to inside will be skin, subcutaneous tissue, supraspinous ligament, interspinous ligament, ligamentum flavum. As we pierce the ligamentum flavum, we'll have a loss of resistance followed by epidural space. As we advance our needle, we'll pierce the dura subarachnoid membrane. That will be the second pop-off and followed by a subarachnoid space. As we reach the subarachnoid space, we'll have free fluid, that is the CSF, flowing through the needle. So now I'll demonstrate how to perform a subarachnoid block. So this is the space identified, that is the L3-L4. So after proper palpation, we'll take a bold prick so that our needle is stabilized. As soon as our needle is stabilized, we'll stabilize our hands as well as the needle and introduce. So we have to feel for loss of resistance. That 2 loss of resistance will be there. Once the second loss of resistance has been filled, we'll remove the stellate and look for free flow of CSF. After free flow of CSF have been confirmed, we'll attach the ladle containing the spinal drug, aspirate for blood and free flow of CSF, and inject the drug.